This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 16, Toxicological Emergencies. Key concepts. When completing this chapter, you'll understand the recognition that a chemical can have adverse effects on the body, the different classes of chemicals cause classic pictures of signs and symptoms called toxidromes, the realization that due to a decrease in the function of their organs, the elderly suffer great adverse effects from toxic exposures. Chief concerns here, different toxins produce different effects on different body systems. Many different mechanisms of actions are in play depending on which toxin is actually applied. Several general principles. Consider with all potential exposures. We should look at any potential exposure to where the patient would need decon could pose a scene safety hazard. Route of exposure. Next picture we're going to look at is figure 16.1, 4 routes of toxic exposures, and they are ingestion, inhalation, transdermal, and injected. And this is in your book, figure 16.1. So transdermal, this would be by touching. Injected would be by piercing the outer layer of skin. Ingestion, we ate it or we inhaled the toxin. Time of exposure. It's important to determine the time of exposure and the need for decontamination or other treatment. Serious effects develop from the exposure in general. Most important for ingested toxins may require aggressive decontamination. Nerve or pesticide agent exposure, antidotes for this are a substance to counteract the form of poisoning, and we'll talk about those. Organophosphates or nerve agent poisoning is the most common antidote that we carry on the truck, but we do have other antidotes as well. Toxidromes. And we have several classifications here of medications that we find come up in EMS, or the actual patient population will become exposed to these. First one here is Sympathomimetics. They pretty much mimic the sympathetic nervous system, is what these drug types do. And they stimulate the sympathetic nervous system, commonly referred to as fight or flight syndrome. Multiple things. Every receptor site that the sympathetic nervous system would touch, essentially these things excite simultaneously. So elevation in the hormone levels of epinephrine and norepinephrine. Heart goes harder, faster, stronger. They're anxious, they're tachycardic. Cocaine can cause widening of the QRS, and this would be an amphetamine or sympathomimetic as well, considered as. Major concern is safety. Patients are really agitated if they're on an amphetamine. Anticholinergics is our next one. Anticholinergics work by blocking the acetylcholine receptor sites, and they're essentially, we can call them anticholinergics or anti-parasympathetic. Patients will be agitated, confused, some will hallucinate, they're flushed, they're tachycardic, dry skin, dilated pupils. Cholinergic toxidromes. These are pretty much chemical weapons, nerve agents, and pesticides in this category. The cholinergic toxidrome, nerve ending, motor end plate, target organ. So as the stimulus comes down, hits the motor end plate, we release acetylcholine into this neuromuscular junction, for an example. The target organ picks up the information and then transfers it to the tissue to get our action that we've requested from the autonomic nervous system. Now, what happens is after the target organ accepts the stimulus, you get an enzyme that kind of like breaks down all the excess acetylcholine, and its name is acetylcholinesterase. Now, acetylcholinesterase essentially is the target for the nerve agent and organophosphate poisoning. So what we give the patient is an antidote. One, since it attacked the chloride ion, we give them something called 2-PAM chloride. Well, the 2-PAM chloride is the antidote. It releases the acetylcholinesterase and allows it to function again to discontinue or stop excessive acetylcholine or the acetylcholine that's in the neuromuscular junction from re-stimulating the site. Now, the other thing that we give them is called atropine, and atropine is a parasympatholytic. So if we look at it like this, it abolishes the parasympathetic nervous system, and thereby, since this is the parasympathetic nervous system that is running amok, it essentially solves our symptoms. So 2-PAM chloride is the antidote, and the symptom solver on this is going to be atropine. Opiates. Drugs that are derived from or related to morphine, most of the time they're used as painkillers. Opiates essentially are derived from the poppy plant. Now, the closer we use, as far as an antidote goes, the antidote is Narcan. And essentially, what the opiates do is give us respiratory depression, altered level of consciousness. So what the Narcan does is it competitively competes for the receptor site that it's actually stimulating. The closer we are to the poppy plant, the better Narcan works. The more synthetic it is, the less it works. So things like Darvocet, Lortabs, fentanyl, all of them are opiates. However, Narcan does not work as efficiently on those as it would, say, heroin or morphine. Next one on our list, sedative and hypnotics. This is going to be things like benzodiazepine and barbiturates. They do have an antidote for this. Most EMS services do not carry the antidote for this. It has a high preponderance of causing seizures. Next one on our list is going to be carbon monoxide. As far as toxidromes, carbon monoxide is a odorless gas that's a byproduct of combustion. And what carbon monoxide does is it has a greater affinity for the hemoglobin molecule than oxygen does. So the short answer on this is it overpowers oxygen essentially and binds to the hemoglobin molecule and then doesn't want to let go. Now, to reverse this action, what we generally do is we'll take them to a hyperbaric chamber to where we can adjust atmospheric pressures to the point to where oxygen has a greater affinity than carbon monoxide. We kind of overpower it. Now, some of the hemoglobin molecules are damaged beyond repair due to this at the point. So the patient may need blood. This is a process. It's not something that's going to get fixed instantaneously. Our goals on this would be to provide respiratory control if necessary, high flow oxygen, and get them to a place that can actually unbind the carbon monoxide. Toxic alcohols, a lot in this list, including just normal alcohol that we would drink. Ethylene glycols are in this, methanol. We'll talk about this in more detail, but the toxic alcohols are pretty much like a sedative or a hypnotic. They hit the same receptor site as the benzodiazepines do, or the GABA receptors. They hit a few others as well. Slurred speech, ataxia, altered mental status, nystagmus are some of the symptoms of this. I think we've all seen somebody that's had one too many. Special considerations when going on to it. Elderly and children. And the elderly do not have good liver function. The older that they are, the less active their liver actually is. So the liver detoxifies things in the system. And then children. Most of the medications are weight-based for adults. So if a kid gets a hold of an adult-sized medication, it generally throws them into the toxic ranges quite quickly. Pregnant patients are also a problem because it's always difficult to treat mom and kiddo simultaneously. Some things travel across the placental barrier, some things don't. So we always have to take that into consideration. History. Key elements. Always try to obtain the substance if possible. Sometimes we'll be guessing due to everyone that's on scene that might have applied a history. Has an altered level of consciousness, route of exposure, the amount of toxin, how long were they exposed to it, and what's the timing, and then why the actual exposure occurred. Was it an attempted suicide? Was it accidental? If there's any kind of decontamination that's required, did they have any prior decontamination prior to your arrival, and then any type of treatment. Treatment can even be initiated via EMS dispatch. First responders or fire could have applied some treatment as well, so always try to get that history from your patients and from the actual rescuers. Examination. Considerations. Same general principles of the patient. Paramedic safety is a concern. Decontaminate the patient before you contact them. Some of the stuff, like the organophosphates, they can touch you and you get dosed with it as well. Just be aware of that. Scene safety. Some intoxicated patients are belligerent and combative. Airway, breathing, and circulation. Correct any issues in the primary survey. Evidence of toxidrome and trauma. If there's evidence of trauma, treat them appropriately. If you can identify a toxidrome that they're actually in, please start applying the antidote. The quicker that we apply the antidote, the better outcomes we're going to have on the other end. As far as assessment goes, the MSDS sheets, if we have the ability to obtain like an industrial or a workplace, if they have the material safety data sheet, those are always helpful. If you have a poison control in your area, be sure that you have that number to where you can easily contact them. They have a gigantic database of chemicals and toxins. They can be very, very helpful. Provide important information, substance and precautions, the effect of the exposure, and this is the MSDS sheets, specific treatment considerations, and the absence of a clear toxidrome. Specific agent may be difficult to determine. So if you can't find the actual agent that causes, you're kind of in the dark. So just go back to general treatment, spread your net as wide as you can, and get them to a place to where they can identify the toxin. As far as treatment, scene safety and decontamination, the source of chemical exposures, chemical weapons, or methamphetamine labs are always a concern as far as decontaminating the patient and if we've got exposed ourselves. Precaution for poison patients, we should always play them on a cardiac monitor. If there's 12-lead, could be helpful as well. If they've overdosed on like a tricyclic antidepressant, it will increase the QRS width. So at the point that we widen the QRS greater than 50%, that would be indication to apply the antidote. Finger stick glucose is always helpful as well. Be sure we're not making a mountain out of a molehill. Altered mental status can be easily caused from a low blood glucose. IV access, the basic ABCs, airway, breathing, and circulation in our treatment as well. Always isolated on the primary assessment. Anything that we find in that primary that's aberrant, we should identify and correct immediately. Watch for altered mental status, provide airway management, and provide good ventilatory support. Internal decontamination could also be considered as well. Follow your local protocols on this. Administration of an emetic agent like Ipecac, for most protocols, we've kind of moved away from that. If they have had it in their system for a while and we're trying to bind it up, we do still have protocols to where activated charcoal is administered. So follow your local protocols on that. But Ipecac and activated charcoal may also be an option. If the patient is going to have an altered level of consciousness from the agent or from the toxin, the example of this, a tricyclic antidepressant, we would not want to start throwing on a bunch of Ipecac to somebody that may have an altered mental status later on. Aspirate pneumonia would be a definite possibility. Sympathomimetics. This is just considerations on this. Safety, amphetamines, things like this. People are highly agitated. IV fluids, hypothermic treatment, cooling measures. Everything is going to be in overdrive, including their temperature. Myocardial infarction should also be kind of run side by side in the background. The reason being is because their heart generally starts beating harder, faster, stronger. It may be too much. If they have any type of plaques, even younger individuals, if they're overdosed of methamphetamine, it can ask too much of their cardiac muscle. Myocardial infarction treatment for this would be aspirin. Be careful with anything that would adjust blood pressure, and avoid any type of beta blockers in a methamphetamine or amphetamine-induced chest pain. Anticholinergic agents, safety, agitation, and seizure treatment via IV benzodiazepines. Hypothermic treatment, these people are going to be hot as well. Cooling measures. Arrhythmias and hypotension treatment, IV for hypotension, IV sodium bicarbonate for wide complex tachycardias caused by tricyclic antidepressants, and they can have anticholinergic effects as well. Very simply, follow local protocols, and if you think that you have somebody that has TCA or tricyclic antidepressant overdoses, the antidote for that is going to be sodium bicarbonate. Organophosphate and nerve agents. This is going to be our 2-PAM chloride and our atropine. Considerations on this is timing. If we think that this is a problem, we need to get on the ball. Decontamination and scene safety. Decontamination is the first step. We do not want to be contaminated ourselves. Scene safety, paramedic staging upwind, appropriate personal protection, decontaminate the patient. Nerve agent poisoning treatment is going to be 2-PAM chloride and atropine. Supportive measures, and there's going to be a lot of supporting measures. The seizures that these individuals can have are impressive. Commonly used atropine or prolidoxamine or 2-PAM. Please avoid, for airway management, any type of succinylcholine. Succinylcholine is a synthetic version of acetylcholine that stimulates the motor end plate. They do not need any more acetylcholine in play. So succinylcholine would be a contraindication. Opiates, considered, and this would be opiate overdose. Typical initial steps, evaluating their mental status and providing ventilation. Narcan or naloxone is our opiate antidote. Administration routes for this, it's like it can be administered in any form or fashion almost. IM, sub-Q, IV, sublingual injection, or intranasal. Potential effects, it may give them a seizure, it may give them pulmonary edema, risk versus benefit, or cause cardiac arrest. Whenever you bring somebody out of a morphine or opiate-induced coma, all of a sudden it's like kicking bright lights on. It may be too much for the system. Just be careful with this. Ease them out, is what I'm saying. Sedative or hypnotics. Roofies would be in this as well, into this category. Flamazanil is going to be the drug for the benzodiazepine antidote, seizure risk and treatment. If we bring them out of a benzodiazepine-induced coma with the flamazanil, again, it's just like turning on bright lights. Too much stimulation, we might actually get a seizure out of this. So just be careful with that. Treatment, give larger doses of benzodiazepine to overcome the flamazanil. If you have to be careful, because once you start down this path, you get on thin ice. An example of this, let's say that someone had a benzodiazepine overdose and you gave them flamazanil and all of a sudden they had a seizure. So now, what medication would you be utilizing to stop the seizure? The answer is a benzodiazepine. Always weigh risk versus benefit on this. Sometimes we can just provide airway management and get along with this just fine, and then they can look at the toxic levels. Once the medication wears off, very simply, all of their stuff should return to normal, unless there's been neurological damage. Carbon monoxide, scene safety is way important in this. Self-contained breathing apparatus should be utilized. We do not want a lot of CO ourselves. Initial primary and secondary survey. We should provide resuscitation. Pre-hospital treatment for CO poisoning involves high flow oxygen, high concentrations of oxygen via non-rebreather mask, BVM mask, or endotracheal tube. Appropriate interventions on this is going to be get them to a place that has a hyperbaric chamber, increase the pressure from 1 atmosphere, that's what you're generally at, to about 2.8 atmospheres. Toxic alcohols. Considerations on this: intoxicated or alcohol withdrawal treatment. We should always consider that the patient may be hypoglycemic, and the administration of thiamine if we're considering Wernicke's-Korsakoff. Other toxic alcohol ingestions, as far as our treatment, we should primarily focus on airway breathing and circulation. For methanol and ethylene glycol toxicity, formopidazole is a competitive inhibitor that can be given sometimes. It catalyzes essentially the enzyme that metabolizes ethylene glycol. It's contraindicated with the use of ethanol because it kind of extends the half-life. So you might see this in clinical given, or you might not. Evaluation. Considerations on this: monitoring during transport. Be sure and primarily focus on the airway, vital signs for stability, and any type of EKG changes. If there was a response from the antidote that was given, please observe any type of response, positive or negative, and adjust your treatment appropriately. And disposition considerations. Disposition depends on the resources. If they've had hazardous material exposure, does the emergency department have a decontamination capability? Mass casualty situations, many emergency departments or temporary hospitals may have this capability or be able to fire this up. Good communication is going to be essential in this. Intent to harm themselves or others. Does the emergency department have psychiatric capabilities? Unstable or severely obtunded patients, nearest appropriate emergency room. In conclusion, paramedics will encounter many poison patients. Impossible to remember the specific treatment for each. By grouping poisons into toxidromes, the paramedic can provide appropriate supportive care. References for this were taken from Professional Paramedic Volume 2, Medical Emergencies of Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, roy.smith@redlandcc.edu, 405-219-7613. Thank you.